Welcome to the North Carolina Maternal Health Innovation Community of Practice. We're so excited to have Dr. Joe Quist-Nelson from UNC here to present on postpartum heart health care best practices. So thank you for the housekeeping and for submitting your information. During this session, Dr. Quist-Nelson is going to cover postpartum care after preeclampsia with severe features and best practices in postpartum care after cardiac disease and pregnancy. You are able to ask questions in the chat, and we will try to be monitoring the chat. If there's any questions on a particular slide, we can ask it as we go. Otherwise, we will wait to do question and discussion at the end. And with that, I will turn it over to Dr. Joe Quist-Nelson to share some context about why she's in the work and her background, and then go ahead and get started with the presentation. All right.
Thanks so much. Are we successful with my slides and audio?
Looks great. Thank you so much.
Okay. Well, thanks for having me. This is an area that I care a lot about, and I'm happy to talk with you about it today. As Suzanne said, I don't get overly disarmed if someone has a question while I'm on a slide. So if there's a question about a particular slide, please feel free to mention that in the chat, and Suzanne can interrupt. So I don't have any conflicts, but I do run a joint clinic with colleagues in cardiology to support primarily postpartum patients who have had preeclampsia, also cardiomyopathy, and we do some pregnancy heart care as well out of that clinic. And so a lot of what I'll be talking about comes from my experiences within that clinic at Rex and over the past 2 years. Going through some objectives, I do think that because of the overlap between preeclampsia and cardiac disease, I wanted to make sure that I touched on the both. So first, for preeclampsia, I'll be touching on racism and preeclampsia, patients' perspectives, what postpartum care should look like after preeclampsia, and then postpartum preeclampsia. Looking at cardiac disease, we'll transition with the risk of preeclampsia leading to cardiac disease in the future, as well as how race and racism interplay there, who should be screened, and why this postpartum care is important. I'm going to assume that this group knows the definitions of preeclampsia and cardiac disease, so I won't spend a lot of time on that. I will be detailing our well-told story within our country and within our state about disparities in maternal outcomes and maternal mortality. The reason is that both of these conditions carry high risk for our patients, and I'll be talking about how racism falls as a risk factor for the development of these diseases. I do this for awareness and as I feel that this conversation is ongoing and very important. So let's talk about preeclampsia. In the next few slides, I will be blurring a little bit my phrasing of preeclampsia, gestational hypertension, preeclampsia with severe features. Sometimes I say one or the other. In general, I try to call everything preeclampsia, but it is a spectrum. And so when I say preeclampsia, I'm in general talking about any of those diseases. Most of the data that we have about the burden of preeclampsia compares our patients who are white compared to our patients who are non-Hispanic Black, with our Black pregnant patients having a 2 to 4 times higher risk of preeclampsia, preterm preeclampsia, and postpartum preeclampsia. There are fewer studies looking at other high-risk groups, for example, patients who identify as Hispanic, American Indian, American Native. Because race is a social construct of self-report and there are no genetic bases for these outcomes, the association here is not at all meant to demonstrate causality. Dr. Johnson, who was formerly my colleague at UNC, did a beautiful job writing about this in a health equity framework piece on preeclampsia, demonstrating here on the left that racism can affect the access to any of of these things, all of which could increase the experience of risk factors that can lead to adverse pregnancy outcomes, such as preeclampsia, which I'll be talking about today, and then the interplay here between those things and cardiovascular disease. So we can see that this has an effect during pregnancy and then throughout a life's course. When we think about what a patient thinks about when they are identified as pregnant, they have a timeline in their head, and it's natural. The majority of patients think about a timeline something like what I'm going to show. There are certainly patients who have different perspectives, but the positive pregnancy test leading to the baby shower. This is a picture of Serena Williams' baby shower, which was 50s themed. I recently read a book on tennis and am now a big fan. And then leading to the newborn stage and the newborn pictures. When we add a diagnosis of preeclampsia, this timeline generally changes, or at least the outcomes often change. This is a painting entitled Chaos that is what has been relayed to me by my patients of what they experience when they have these new diagnoses. So I want to give you an example of this from some works that I'm doing with Dr. Tully, who's also on the call. This is a patient interview of a patient who experienced preterm preeclampsia. She said, I mean, my delivery in general, everything was unexpected, and everything was essentially we were unprepared for. You know, I wasn't prepared to deliver early. I never considered having, that I would even need to have a cesarean section. I never thought I'd be hospitalized. I'd never been hospitalized in my life. So everything about the delivery was completely unexpected. And there's no way to really be prepared for it. I think post-delivery, I felt incredibly blindsided. The themes that are in this quote, I see in my interactions with my patients, whether it be in the hospital, at that first postpartum visit, at the 1-week blood pressure check, or in our combined clinic. There's a lot of surprise with these diagnoses. There's a lot of, some patients even experience shame and blame, feeling like their body failed them. And so trying to describe that those things weren't the case, but yet honor their feelings is an important thing that we can do as providers. Here's a list of questions that I ask my patients in the postpartum period after they've experienced preterm preeclampsia. How have you balanced your health and having a baby in the NICU? Who's supporting you right now? What are you most worried about? Very important, who is your primary care doctor? And what is your understanding about how preeclampsia can play into future health? I try to aim for open-ended questions, and sometimes patients aren't concerned about any of these things and there's something else. I've had patients come to my clinic unaware that they had a diagnosis of preeclampsia without a full understanding of why they were on magnesium. And so being able to explain those things and talk about things afterwards can be very helpful, and in some patients can lead to some closure and understanding. When we think about the treatment of preeclampsia in the postpartum period, I think of 4 main things that are important to do. Postpartum depression screening, so important. Screening for the patient's symptoms. We know now that maternal mental health is a leading cause of maternal mortality, and our patients with preeclampsia are at increased risk of postpartum depression. Hypertension treatment. Within the field, we really like medications such as Precardia and nifedipine, and that treatment generally needs to be changed in the postpartum period, whether it be increased or decreased, titrated off. And so frequent appointments during this time frame are important for the high blood pressure medication alterations. Then when we see our patients, we have to talk about how they're feeling and what their primary symptoms are. Our patients with preeclampsia are at increased risk for strokes, for renal failure, for other complications. And so looking at their symptoms and deciding if they need a further workup or to return to the hospital should prompt those things. And then I want to take a moment to talk about edema, because sometimes my patients come to me and that is their actual major concern, because their legs are not something that they can even appreciate or recognize anymore. I guess recognize is a better word. Often it can be even painful because the skin is just so tight. One option for treating that edema includes the use of furosemide or Lasix in helping them clear off some of the extra fluid that has moved into the tissues because of the pathophysiology of preeclampsia. Here's a study that looked at the use of furosemide in the postpartum period. They randomized over 100 patients with preeclampsia with and without severe features, so both were included in this cohort. And each of those patients were either given a placebo or a 5-day course of 20 milligrams of oral Lasix. And this study has been done in different populations several times throughout the past decade and a half. This just happens to be the most recent one. What they found is that the use of furosemide in the postpartum period reduced and resolved hypertension faster, faster time to recovery. And this was especially notable in patients who did not qualify as preeclampsia with severe features. I find that my patients are most appreciative of the change in their legs, though, and the edema and the ability to ambulate a little bit better or move around easier because the swelling has decreased. One thing I want to mention about using furosemide in the postpartum period is that some clinicians have brought to me the concern about potential effect on breastfeeding and breast milk supply, which is a valid concern. That was not something that was investigated in this or any of the other randomized control trials that I have reviewed, and continues to be a valid concern. It's also a valid concern, though, if we're not controlling patients' blood pressures, that they are at high risk of readmission. And some of the studies do show a decreased risk of readmission if we do these short courses of diuretics. Briefly, I want to touch on preeclampsia that is actually diagnosed in the postpartum period, because this is a smaller group of patients, but can be a little bit confusing. So these are patients who had normal blood pressures in pregnancy and then were diagnosed at 48 hours postpartum to 6 weeks postpartum. And this is a diagram that I've broken up a little bit to show a potential workup and diagnosis. And while I think of postpartum preeclampsia not as a separate entity, again, part of that spectrum of care, it can be diagnosed postpartum in the hospital or at discharge. So the first thing that this diagram shows is that if you have elevated blood pressures that are less than our severe range blood pressures, we can identify that and call that as postpartum hypertension. However, if you have blood pressures that are severe range, this should be identified as preeclampsia, postpartum preeclampsia. Now, we know that the presence of protein doesn't relate to our patients' outcomes. Even large amounts of protein don't necessarily mean that our patients are going to have good or bad health outcomes at the present or long term. But within medicine, we tend to use the term preeclampsia as a more severe disease. And so adding the proteinuria here and then also the severe range blood pressures would meet diagnosis for postpartum preeclampsia. Now, this diagram then details out to the right other symptoms that patients can present with. So next comes heart failure symptoms, which we will go through when I get to the heart disease portion, but problems breathing, sitting up in order to sleep are the two primary symptoms. Neurologic symptoms such as a severe headache, and then lab testing. And each of those should prompt a further workup. taking a look for peripartum cardiomyopathy or for a stroke or for acute fatty liver of pregnancy. And if those things are then excluded, then we end with the diagnosis of postpartum preeclampsia. And then there's a little star at the bottom of this that says there can be overlap here between a postpartum preeclampsia patient and, for example, peripartum cardiomyopathy, which we absolutely know. In the past 2 decades, our medical literature has started to show that patients with preeclampsia do have double the risk of developing heart disease in the future. And that risk is going to be highest for our patients who have preeclampsia in multiple pregnancies. And there's a graded relationship with the risk of heart disease being more severe for a patient who has more severe preeclampsia or is diagnosed earlier in the preterm period. The mechanism or the reason for this is still being explored. Some reasons that are discussed include the idea that there could be a common pathway that could lead to a patient developing preeclampsia and then later developing heart disease. But it is thought that there may be something about preeclampsia itself that can lead to endothelial damage within the blood vessels and later lead to cardiovascular risk. The tricky thing about this is, how do we share this with our patients? I think about when I had my first pregnancy and how overwhelming that was. I felt like I was entering a whole new realm in the postpartum period. A whole new world was opening up to me. And so when you add on the layered stress of a NICU baby or a diagnosis or hospitalization that you had not intended, and then explain that this can carry future heart risk, it can be very overwhelming to patients. And that's why I put here that the sharing of this information with our patients is a work in progress and something that's being worked on a national stage. It's important that our patients know about this because there are modifiable risk factors that we can work on. But how can we do it without alarming or scaring a group of patients? I try to avoid the statistics and talk unless they want something very specifically, and then focus on what we can actually do. So in our combined cardiac clinic, we spend a lot of time talking about diet, emphasizing the benefits of the DASH diet or the Mediterranean diet. We spend a lot of time talking about exercise, with the national recommendations being for 170 minutes of low impact exercise a week. We also emphasize the importance of annual screening because early diagnosis of the chronic diseases like high cholesterol or high blood pressure outside of pregnancy and treatment with those appropriate medications can further decrease that risk to the patient. And I find that patients who have just gone through the pregnancy process can be open to these changes and interested in how they can modify their life. So this ends the portion where I'm talking about preeclampsia, and because I've now transitioned to the risk of heart disease, I'm going to talk about heart disease in the postpartum period. A lot of what I'm going to show you are toolkits and things that are designed for pregnancy with the idea that postpartum was captured as part of that. And the reason for that is because the timing of pregnancy-related deaths, the majority of those are occurring in the postpartum period. And so the teams that are responding to these patients when they first present with these complaints are the primary care doctors, our midwives, the OBs, family medicine doctors, and our emergency departments often are seeing patients because the symptoms are not always happening in the hospital. Next, I'm going to show how maternal heart disease plays a large role in maternal mortality. So this is a study which combined data from 9 states in the maternal mortality review committees, and they looked at the cause of pregnancy-related deaths. And what I have highlighted here with that red box is that the vast majority of the pregnancy-related deaths from heart disease were considered by the committees that reviewed them, were considered to be preventable, which is truly the most heartbreaking part of our statistics. And when we break these down, now the slide is a little bit busy, but when we break these down by different periods, so this is the percentage of pregnancy-related deaths. And first we have during pregnancy, day of delivery, 1 to 6 days postpartum, a week to 6 weeks postpartum, and last leading up to the year postpartum. I've put little hearts on each place where maternal heart disease plays into these statistics. And you can see that it's a large proportion of these pregnancy-related deaths. And if you look at the very far right, cardiomyopathy is a peripartum cardiomyopathy is something I'll be touching on as well, because that carries a very high risk for our patients in the postpartum period. To briefly touch on patients who come into a pregnancy or postpartum with pre-existing heart disease, I want to review our modified World Health Organization risks. So here the World Health Organization has grouped heart disease that is pre-existing or found in pregnancy by the type of disease. And they put those into 5 different categories, which are labeled 1 to 4. And the 5th one in the middle is class 2 to 3, meaning the patients can act more like a class 2 or can be more like a class 3. And what we're showing in this slide is that with the increasing assignment of the World Health Organization, thus, if you are World Health Organization class 4, you have a very high risk pregnancy and have a much higher risk of these complications. So if we take these conditions and we break them out, just like they are in this slide with this little dashed line in the middle, to World Health Organization 1 to 2 versus those who are 2 to 3 and higher, we see a big difference in outcomes. And here's some data for our state. Within North Carolina, for example, if we look first at the picture on the left, which has the more of the blue squares, these are data of North Carolina births, and we are looking at the blue dots as patients who do not have any heart disease in pregnancy. The orange dots are those who are modified World Health Organization class 1 to 2, so the lower risk group. And these 3 red dots here, again, all the way on the left, demonstrate our patients who are class 2 to 3 and higher. And so that is a very small group of our patients who deliver in the state of North Carolina, only 3 per 1,000, as is bolded on the left. But if we turn and we look to the right and we see which patients have cardiac complications, listed here as cardiac severe maternal morbidity, that is primarily represented by those 3 patients in 1,000. So what these data, which come from my colleague Jeff Fetterspiel at Duke, what these data show is that patients in North Carolina who have World Health Organization class 2 to 3 or higher have a 50 times increased chance of having a cardiac complication during their delivery admission. And again, because I have already talked about how important the postpartum period is, these data extend to the postpartum. And because I think it's important to talk about the differences that we see and the racial disparity that we see in our population, similar to preeclampsia, we can see over on the right, figure B, patients who identify as Black have a 4-fold increase of cardiac complication when they have a diagnosis of heart disease that is of that higher group, higher risk group, the modified World Health Organization class 2 to 3 or higher. When I look at these statistics, they can become overwhelming and very depressing. And I like to think about what can I do next, especially as an individual provider and doctor. And that's where I have come to review the information available through the California Maternal Quality Collaborative. Back in 2017, they put together a toolkit to look at improving heart disease and the response of the healthcare system to heart disease in pregnancy and postpartum. In their introduction, they talk about how it's confusing. Most pregnancies occur in young, healthy patients, and there is significant overlap between the signs and symptoms of heart disease and those of a normal pregnancy, i.e. shortness of breath, fatigue, limitations in exercise capacity, and swelling. That's true. I remember trying to go for a run when I was pregnant with my most recent pregnancy, and it was laughable. And I'm someone who usually can exercise. So there can be overlap. The body is changing so much. And so trying to identify the patients who really need to be worked up for heart disease is the big challenge. Within their toolkit, they identify some red flags that I want to review. And that is shortness of breath at rest, severe orthopnea, meaning you have to sleep sitting up in order to keep your breath. And then vital signs that are very concerning, including an oxygen saturation. Anytime I have a patient with a history of heart disease, I always encourage my staff to get an oxygen saturation. Fake nails can make it difficult, but abnormal values should be investigated. And so these are red flags according to this quality collaborative of things that should either prompt a hospitalization or a quick evaluation. And again, these very much apply to the postpartum period. Now, not every patient comes in and says, you know what, I'm sleeping with 4 pillows at night and I couldn't even walk into the office today. Often the concerns that our patients have are symptoms that are more mild than what was just presented. And so this is the second part of their algorithm where they talk about combining the symptoms, the vital signs, the risk factors, and findings on physical exam to prompt a workup. Now, the number of arrows on this, I think, is a little bit confusing, but if we jump to the first black and white box down there where it says obtain EKG and BNP, I find that this is really helpful. First of all, stratifying my patients, thinking about what their symptoms are and vital signs, and having a low threshold to do this workup is one way to capture our patients who truly do have heart disease in the postpartum period. They mention here different options for workup, including an echocardiogram, a Holter monitor, a chest x-ray, and labs. And making sure, you know, that bolded part at the bottom, making sure that if the patient is remaining outpatient, that the patient should be seen within a week. And then if any results are abnormal, then heart disease would be really suspected and should be, patients should be seen by a cardiologist if available, and or be seen in the hospital. When they took this screening tool to the state of California, and they retrospectively looked at the cases of maternal death, they found that 88% of cases within their state would have been identified earlier if the toolkit had been used. My understanding is they are currently prospectively validating this toolkit. Not just the state of California, but also ACOG has put together an emphasis on screening patients, looking at their family history, their comorbidities, and their vital signs. And they have a similar idea of talking to our patients about these symptoms. For example, talking to a patient who is pregnant or postpartum about shortness of breath, something that doesn't interfere with daily living or is only with heavy exertion, compared to a new diagnosis of asthma, which is really unusual in an adult and always makes me concerned. A continued cough or severe problems breathing. Moving over here to the red column, looking at severe problems breathing at rest or orthopnea, as I've mentioned a couple times. These algorithms can help us standardize the way we think about each of our patients and help us decide who does need a workup further, and allow us These are part of the AIM bundles, which the goal is to have a response and a recognition of our patients and provide those respectful approaches to care. Just a couple more slides that I want to share with you. Because the BNP or the B-type natriuretic peptide was on that last slide, I do want to mention that the BNP can change during pregnancy if preeclampsia is diagnosed, where the levels do go up. Those have been shown to increase. With the average level in preeclampsia being right around 100, which is where the threshold for abnormal is at many labs. The mean level of a BNP in a patient with heart failure is generally much higher, but we know this test isn't perfect. It has less sensitivity depending on the patient's body habitus, for example. So sometimes this is not the best test, but it is a good screening test because if it is abnormal, we should absolutely be doing a workup for reasons that I'll show you on my next slide. If it is normal and a patient's symptoms are persistent or there are any other concerns on the workup, the patient should still get an echocardiogram and further workup. The reason for talking about the BNP is really to screen for this very concerning diagnosis of peripartum cardiomyopathy. The diagnosis can be made when the ejection fraction or the amount of blood coming out of the left side of the heart is low. Normal would be 55% or higher. And once that level reaches 45% in pregnancy or postpartum, it is considered abnormal. This diagnosis is made if that squeeze of the heart or the ejection fraction is less than 45% and the patient has had no prior history of heart disease. If a patient is diagnosed with peripartum cardiomyopathy, there is a 20% risk of recurrence in another pregnancy. And patients who have a lower ejection fraction have poor outcomes. With most of our patients recovering, but those who don't have a significant risk of maternal mortality within that year postpartum. So this is a disease that we should really be thinking about when we are doing that screening that I just showed you in the postpartum period. So that takes me to the end of my points about postpartum preeclampsia care as well as postpartum heart disease care. I'd be happy to take any questions, and I have some references here.
Thank you so much. We do have a bunch of questions in the chat that I will go ahead and ask. Let me zoom back up. And then for our—
Stop sharing my screen.
Yes, sure.
Okay, perfect.
And for our nurse champions and clinic sites you feel free to go off mute to ask any questions as we go as well. Otherwise, I'm going to start looking through the chat, and then if you have some spin-off questions from that, please interrupt. All right, I'm moving up. I know Velma had a question. I believe it was answered. But Joe, when are you seeing these patients? How far into the postpartum period? And this was, I think, when you were covering the preeclampsia section.
Great question. Preeclampsia patients are recommended to be seen within a week of discharge by their primary obstetric provider for the blood pressure monitoring. So that is commonly referred to in the hospital as the 1-week blood pressure check. And then again at the 6-week postpartum. But if something is abnormal at that 1-week visit, they should really be seen again. In our joint clinic with cardiology, where we review these with the patient, we are more a consultative service, and so we don't have any particular goal timing. We do try to see patients within 3 months postpartum, but we've seen patients 3 and 5 and 10 years after preeclampsia as well.
Yeah, Joe, I was trying to get a sense of, like, if I'm seeing a postpartum patient on that slide where you were talking about using furosemide for edema. So I was just trying to get a sense of, if I'm seeing them in that first 4 to 6 weeks, is that something that I should be thinking about on a more, I mean, I can tell you, I've never done that. But
Yeah.
yeah, so it was just like, I'm expecting that to resolve, right? So is that something that we should be more proactive about that early on? Or is that something that if you see edema 3 months out, right?
So great question, Melma. If I see edema 3 months out, I'm really worried. Like there's no reason why we should be looking for heart and renal reasons why a patient has significant edema. When I'm seeing a patient a week out and they're still having edema, particularly if they were mild preeclampsia, I am prescribing Lasix. I tend to do it more liberally than I think most of my colleagues, just because I've read these studies and I've seen the improvement that patients have. And I think that a 5-day course of Lasix 20 milligrams overall is a very low risk intervention. So I would do that up until 4 to 6 weeks postpartum if they're still complaining. But after that, I think they warrant more of a workup.
Sure. Okay, great. Thank you.
Yeah, absolutely.
And then thank you, Dr.
Hey, Jeff.
She put some information in the chat, a couple links to around that topic. The next question, how can we support transitions of care for patients with cardiovascular disease? I know a lot of our clinic sites are, that's a particular interest of this transition of care and different care touch points. So any best practices there?
Yeah, yes, I definitely do. It depends on what the heart disease is, right? There's a whole spectrum, and that's why the World Health Organization has done such a good job organizing patients by low and higher risk. A patient who has, let's say, anything World Health Organization class 2 to 3 and higher should really be seen 1 week postpartum by their primary obstetrician or obstetric provider, I should say, and then should really be seen by a cardiologist within a month to 2 months postpartum. And that transition of care is a challenge, making sure that every team member is aware of this goal. Most importantly, the patient is aware of the goal. And then this is where primary care providers are just essential, especially in our rural areas. And I really respect the work that is being done out there. I would love to brainstorm ideas to improve that transition of care because I worry about it for our patients who've had known heart disease and got a lot of attention during pregnancy. And I worry about that year and 2 years postpartum. I think this is an area for research and more discussion. I don't have any concrete answers right now.
There was a 2-part question. They're not related, but I'll just ask them one at a time. Are there key points that we should know as a state? And I guess maybe North Carolina specific policy. I think that was
any key points, sorry, that we should know as a state.
And maybe this is related to transitions of care.
So I'm not entirely sure what that question's asking, so I'm probably going to move on unless someone wants to clarify. And then the second part of that question that I'm looking at now, are there efforts dedicated to implementing the new AIM bundle? Yes, I believe that is being carried out, and Dr. DeVenti, I think, is on the call and can comment on that.
On the spot. And then Heather White also had a question.
Hello.
Hey, Jim, go ahead.
Hey, I'm sorry. I was trying to listen to, I must admit, I don't completely, can you repeat that question?
Oh, the question was about how Picnic is moving at rolling out the AIM cardiac bundle.
Oh, well, our goal is to try to implement it from a Picnic standpoint in January of 2024 in 2 regions. And then and depending on how that work goes, to then implement it throughout the entire state. Is that Does that answer the question, or was it?
I think that does. Thanks so much.
Okay. So I have a question for you, Joe.
Yeah.
Have you ever used hydrochlorothiazide instead of Lasix?
Yeah, I use it a lot. It's not my first line because we have these randomized controlled trials on Lasix that are recent and generalizable to our population here in North Carolina. The one that I showed was done in Philadelphia.
Right.
So I tend to use Lasix first, but I have used hydrochlorothiazide, particularly in my patients with heart disease as they recover in the postpartum period.
You know, I know that, you know, all clinical environments tend to have their own little customs, and we've been using hydrochlorothiazide for years in our patients with symptomatic edema in the immediate postpartum period. But I'm, you know, maybe we should be using Lasix instead. The whole logic for us using hydrochlorothiazide is, you know, trying to find something that's more potassium sparing.
Yeah, definitely. If someone's on long-term Lasix, I'm definitely watching their potassium. But with a 5-day course, my understanding is the risk is really not significant of having low potassium, and so I don't trend potassium levels unless I have other reasons to be checking those in the patients. But you're right, hydrochlorothiazide is potassium sparing and has that benefit, and is certainly can be used.
Well, thank you so much. Great presentation, great slides. Will we all be able to get a copy of this so we can plagiarize your talk, or do we have to ask for special permission for that?
We have the recording. We don't typically share the slides, but I do have the recording that we can share afterwards.
Happy to share my slides, Jim.
Right. I think under special requests, you can ask Dr. Quist-Nelson. Great. And there was one more question, I believe, in the chat from Heather White.
Yeah, given recent findings during pandemic with pulse oximetry measurements in patients of color, is there another parameter to be measured, or should we use a different threshold? Thanks for your question. I don't use different parameter measurements for my patients of color. I try not to explain away abnormal findings. I have clinically not seen differences in my pregnant and postpartum patients based off of my patients' skin tone or color. I do note that a lot of my patients have fake nails. They're ready for their baby shower pictures, or they're ready for their postpartum pictures. And so I do make my nurses take pulse oxes on the feet sometimes, but I don't use any different thresholds for different patients' race or skin tone.
Very interesting.
I have a question, Joe.
Mm-hmm.
What do you think helps around symptoms? It's so striking, isn't it, that part of understanding the severity and the continuation of how people are doing is their report of what it feels like, you know, with breathing, as you said, sleeping, and it's so hard because it overlaps, as you also shared personally, with normal course.
Mm-hmm.
And so I just wondered if you had reflections on what's helpful for people in their daily life to identify and to track and communicate with their team around, you know, what it feels like.
Great question, Kristen. I really think that sudden changes are super important. So a gradual change from 12 weeks to 36 weeks of exercise intolerance that that's okay. So sudden changes within hours or days of breathing are very concerning. Orthopnea, it really should always be investigated. The idea that you have to sit up in order to sleep at night. A lot of patients have that because of reflux, but in general, if it involves a lot of questions, because a lot of patients who are pregnant sleep with lots of pillows in different places. And so you just have to be specific about how they're sleeping. Other warning signs are the things that would classify someone as New York Heart Association Class 2 or higher. So having trouble walking a block, even in a pregnant patient, especially if it's just a single pregnancy, just one baby, then that's really concerning to me. And then one that I have seen missed several times is escalating asthma needs. So a patient who has a history of asthma and is needing more and more medication, or a patient who has a new diagnosis of asthma in pregnancy or postpartum, is a big red flag to me. And I think sharing those things with my patients, especially if they have a history of heart disease, is important, and is a lot of the counseling that goes into their prenatal and postpartum visits.
Thank you. And the other thing that's very striking on my mind is not everyone is informed about their diagnosis. And so I wondered, perhaps not your feelings, but the actions that we might collectively take to shift that, so people are aware and supported throughout their journeys.
Yeah, I mentioned earlier on that preeclampsia is a spectrum, and we see patients during their pregnancy and postpartum move across the spectrum. Maybe at first they just had gestational hypertension, and it's just explained to them that they have concerns about the blood pressures, and then things escalate and they end up in the hospital. And now they have preeclampsia, but they still just heard the first thing that was said, which was, we have concerns about your blood pressure. I do think being specific about diagnoses is helpful. I often will sit down with my patient and just say, do you know what's happening to you? What's your understanding of what's happening to you? Not as a test, but to make sure that I'm able to corroborate with what they've heard earlier. I think that a lot of the work on postpartum discharge instructions are important, and potentially being as specific as possible on paperwork can be helpful, but not everybody reads the paperwork. Those are some initial ideas that I have.
Well, I so appreciate your time today. Is there any other questions or thoughts of discussion? I mentioned in the chat, we do have hopes to eventually create a reel. That was something in the back of our team's mind about kind of, we did the science of postpartum hormones with Dr. Allison Stubbe. Similarly, we were hoping to do one on blood pressure and on preeclampsia, like what's happening to your body, where we're really kind of explaining like what's going on, what does that mean, how might it show up? So has not begun, but that is just something that our team has on our radar. In the chat, there's an evaluation link for today's session. I will share that the next session, we're hoping to be able to start offering nursing contact hours. So please do RSVP, and if you have questions about receiving nursing contact hours, you can contact Kimberly Harper or myself. And that is for our June 22nd community of practice. You can rewatch the sessions, including this one. It'll be on our MHI website, and then you'll also get an email about it. And then, as requested from our nurse champions and our different health sites, is that we do have a flyer now available. With one side has New Mom Health content, where it talks about what's on the New Mom Health website for parents and the different sections of care. And then the bottom portion is for health teams, and that includes our postpartum toolkit. And the back page is the urgent maternal health warning signs. because I know some of the teams were trying to create one themselves, and we said that we would go ahead and make an official flyer. So we are getting those PA2 approved. It's translated into Spanish. Hopefully we will have it ready to start distributing. And when I say maternal health warning signs, it's when to call 911 and when to call your provider with a QR code for all of the signs. So you can keep an eye out for that. I so appreciate everyone's time today. Especially I appreciate Dr. Joe Quist-Nelson for being here and sharing such amazing content, everyone, for the great questions. And I hope you have a great day, everyone. Take care. Thanks, everyone.
Have a good day.
Thank you all.